Hello and welcome to your Integumentary and Wounds lecture. To get started, the skin is the largest organ of the human body and it plays a crucial role in maintaining a human alive. It is the first line of defense, protects from overgrowth of organisms or from organisms getting into the body, and the nurse plays a crucial role in maintaining the integrity of their patient's skin. Any break in the skin can potentially be life-threatening. Early prevention and intervention are vital. Here are your learning objectives. Make sure you're able to answer them as you go through the PowerPoint. The skin, like mentioned before, it's the largest organ in the body, has several functions that help us. First, its protection acts as a barrier to water, microorganisms, and damaging ultraviolet rays of the sun. Protects against infection, injury to underlying organs, and then prevents loss of moisture from the surface and underlying structures. Temperature regulation draws heat from the skin as precipitation occurs and evaporates. Dissipates heat as blood vessels in the skin dilate, compensates for cold conditions with constriction of blood vessels, and compensates for cold through the contraction of the pilomotor muscle, or what we know as goosebumps. Psychosocially, contributes to external appearance and is a major contributor to self-esteem, plays an important role in identification and communication. Sensation, it provides the sense of touch, pain, pressure, and temperature through millions of nerve endings, allows the body to adjust to the environment through sensory impulses in conjunction with the brain and spinal cord. The skin also produces vitamin D. It is activated by ultraviolet rays from the sun to produce vitamin D. Kind of think about that. People in Arizona are super low in vitamin D, and it's because we often don't want to be outside in the sun. In addition, we know that being out in the sun can be damaging to the skin. Immunological responses, it triggers an immunologic response when the skin is broken. In absorption, so we know that there are topical medications, and putting them on the skin is where we get the medications to work. And then elimination, excretes small amount of water, electrolytes, and in waste in the form of sweat. Take a look at this photograph. It shows you anatomy of the skin. This is just for review purposes. Please ensure you understand the different layers of the skin and the anatomy so that you can understand conditions of the skin. So we have the epidermis. It's protective waterproof layer of keratin. Cells have no blood vessels of their own, regenerates easily and quickly. Then we have the dermis, which is your middle layer. It's elastic, made primarily of collagen, consists of nerves, hair follicles, glands, immune cells, and blood vessels. And then you have the subcutaneous layer, which is kind of what it's your fat. So it anchors the skin layers to underlying tissue. It's the last layer of protection before you can get to any organs. So how do we assess the skin? So we prepare the patient, explain the purpose, provide privacy and coverings. We only assess one portion at a time. We don't just completely uncover our patients. Ask appropriate assessment questions. Inspect the entire body, including mucosa, scalp, hair, and nails. General appearance such as color, temperature, moisture, texture. Assess any lesions, palpate and measure. Note hair distribution, and photographs may be used to document the nature and extent of skin conditions and to document progress resulting from treatment. You'll see this with a lot of wound care nurses. They take photographs of all the wounds that they take care of. That way they can document and see the progress of the wound care they're providing. During the assessment, you're going to be asking health history questions such as questions about hair, skin, any hair and skin products, as well as any family or personal history with skin allergies or allergic reactions to food, medications, chemicals, previous skin conditions, and skin cancer, or any history of this for them or their family members. The physical assessment, you're assessing skin color. So, you're trying to note if there's any hyperpigmentation or hypopigmentation, vitiligo, those white patches that can occur in certain conditions. You also want to assess for any abnormal skin conditions, discoloration, such as cyanosis or ecchymosis, which is bruising, jaundice, which is yellowing of the skin. You're also noticing pallor, which is paleness if they look pale. And things to note with pallor, on a light-skinned person, they're gonna look very pale, more white. And whereas a dark-skinned person, their skin may appear yellow, brown, dull, and dark black skin may appear ashen and gray. You also want to look for cyanosis. If you want to know that in dark-skinned people, cyanosis can appear more grayish or purple. Erythema or redness. In dark-skinned people, it might look purplish or gray tinged. And so you want to be able to assess this. In jaundice, in dark-skinned people, you might be able to see it on the palms of their hands or the scleras of their eyes. When assessing the nails, you're looking for configuration, color consistency, you're looking for bow lines, ridging, hypertrophy, pitted surfaces, spooning, clubbing. You're looking for any trauma to the nails. And for hair, you're looking at color, texture, distribution. Is there albinism? Is there hair loss? Think of albinism or hair loss. You can think of patients with alopecia, or if they're going through cancer treatments and things like that. So we're assessing that portion. Take a look at figure 55-6 in your MedSurg textbook. It'll show you different nail configurations and what's going on. The gerontologic considerations or normal signs of aging. You can see thinning of the skin, uneven pigmentation, wrinkling, skin folds, and decreased elasticity. Diminished hair, increased fragility, and increased potential for injury, and reduced healing abilities. Think about when we're checking for skin turgor is an older adult. Where would we check that when we know that their elasticity has diminished due to less production of collagen and less protein in the body? So likely skin turgor is not a ideal indication for dehydration on the older adult, just because they do have potential to have decreased elasticity and collagen. You can see some visible changes, including dryness. You can see thinning skin. You might be able to see veins and arteries on someone's skin. Take a look at the picture. In here, you can see these veins in detail just because their skin is so thin. In addition, they have lost subcutaneous tissue substances such as elastin and fat, which is protection and cushioning of our tissues and organs. There are decreased muscle tones, can result in loss of insulation. So this is why older adults are often always much colder. Understand that there are many skin lesions that are a normal part of aging, and we will go through some of them as the PowerPoint goes through. Here are some common skin appearances, medical terminology that you should know. So erythema is redness, and then rash, it can be any kind of unusual appearance of the skin. They can be raised, it may be flat. Cyanosis, you can see it in the picture A. It's bluing of the skin or bluish tinge of the skin. Jaundice, like I said, is yellowing. And then pruritus is itching of the skin. Now that you have a brief review of the skin and how to assess, we're going to move into our wounds. There are different classifications of wounds, or intentional, which are surgical, such as incisions and flaps and things like that. Unintentional, such as that occur in traumatic accidents, maybe like a compound fracture or an open wound, a bullet wound, things like that. Neuropathic or vascular, that it just depending on the type of wound, it might involve nerve, it might involve vasculature. Think of diabetic wound versus a vascular wound. Pressure-related wounds, we're going to talk about those. Those are your pressure ulcers. And then open and closed. Some wounds can be closed, some can be open, and then they can be categorized as acute. Acute is fast, it occurred rapidly, and then there can be chronic wounds. Partial thickness, full thickness, and then complex style wounds. So your open or closed wounds can be caused by intentional or unintentional trauma. The skin surface is broken, which is a portal of entry for microorganisms. There's bleeding, there might be tissue damage, there's risk for infection, there might be delayed healing. Abrasions or incisions are opened wounds, versus closed wounds are typical, like force trauma, blows to the face. Think of like a ball hitting you in the face. You get a big bruise. That is a closed wound. You might get a hematoma. So the skin is not broken, but there is soft tissue damage and internal injury, and there can be hemorrhage as well. Typically, you'll see those as ecchymosis or hematoma. Acute wounds typically heal within days to weeks, while chronic wounds can take longer than 30 days to heal. The wounds remain in the inflammatory phase of healing. Chronic wounds include any wound that does not heal along the expected continuum of time. Examples of that could be arterial wounds, diabetic wounds, or venous insufficiency wounds, and pressure injuries. Take a look at Table 33-3, types of wounds in your fundamentals textbook. These are the wounds that you are going to find in that table. Be able to at least briefly define what each is. You must understand the principles of wound healing. So remember, intact skin is the first line of defense against microorganisms. Careful hand hygiene is necessary when caring for a wound. The body responds systemically to trauma of any of its parts. An adequate blood supply is essential for normal body response to injury. Normal healing is promoted when the wound is free of foreign material. The extent of the damage and the person's state of health affects wound healing. And then response to the wounds is more effective if proper nutrition is maintained. Nutrition is a huge portion of wound healing. You'll learn this in your nutrition and GIGU section, but protein and vitamin C are crucial in wound healing. There are phases of wound healing. There are 4 phases. The first phase is hemostasis. It occurs immediately after the initial injury, primarily to stop the bleeding and activate the white blood cells to fight any invading bacteria. It involves blood vessel constriction, and blood clotting begins through the platelet activation and clustering. This coagulation results in the formation of fibrin clot. The temporary clot forms, then the body releases substances to dissolve the clot. And then it stimulates other cells to migrate to the injury to participate in the next phase of healing. The next phase is the inflammatory phase. This phase follows hemostasis and lasts about 2 to 3 days. This is where all the white blood cells accumulate, macrophages move to the wound, and then leukocytes arrive first to ingest bacteria and cellular debris. About 24 hours after the injury, macrophages, so larger phagocytic cells, enter the wound area and remain for an extended period. These macrophages are essential to the healing process. They not only ingest debris, but also release growth factors that are necessary for the growth of the epithelial cells in new blood vessels to help with that healing. These growth factors also attract fibroblasts that helps fill in the wound, which is necessary for the next stage of healing. After a brief period of constriction during homeostasis, the blood vessels dilate and capillary permeability increases, allowing plasma and blood components to leak out of the area that is injured, forming a liquid called exudate. So think of when you have a cut, first you bleed, and then you start maybe scabbing up a little bit, but then you notice a little bit of clearish fluid coming out. That's your exudate. The next phase is your proliferation or repair phase. The fibroblastic regenerative or connective tissue phase. It encompasses the process that results in actual healing. This phase lasts for several weeks. New tissue is built to fill the wound, spaced primarily through the action of fibroblasts. Fibroblasts are connective tissue cells that synthesize and secrete collagen and produce specialized growth factors responsible for inducing blood vessel formation, as well as increasing the number and movement of endothelial cells. The new tissue is called granulation tissue and forms the foundation for the scar tissue development. It is highly vascular, red, and bleeds easily. In wounds that heal by the first intention, epidermal cells seal within 24 to 48 hours, thus the granulation tissue is not visible. The last phase is your maturation or remodeling phase. It may begin about 3 weeks after the injury, possibly continuing for months or years. Collagen that has haphazardly deposited into the wound is remodeled, making the healed wound stronger and more like adjacent tissue. New collagen continues to be deposited, which compresses the blood vessels in the healing wound so that a scar or an avascular collagen tissue appears. So your scars typically does not have any vasculature, and it doesn't allow for sweat, growth of hair, or tan in sunlight. It'll eventually become flat, thin lined. Scar tissue is less elastic than uninjured tissue. The strength of scar tissue remains less than 70 to 80% than that of normal tissue, even for many years afterwards. This is a nice little graphic of how the phases of wound healing. The only one that's not pictured in this graphic is your hemostasis portion, but it does really well of showing exactly what happens through the inflammatory phase, proliferative phase, and the maturation phase. Picture that depicts the phases of healing. This one does include hemostasis. Some local factors affecting wound healing include pressure. Pressure disrupts the blood supply to the wound area. Persistent and excessive pressure interferes with blood flow to the tissue and delays healing. Desiccation. Desiccation is the process of drying up. Cells dehydrate and die in a dry environment. This cell death causes a crust to form over the wound and then delays healing. Wounds that are kept moist, not wet, but hydrated experience enhanced epidermal cell migration with epithelialization, which is epithelial cells form a new surface layer. Maceration is overhydration, so that's the opposite of desiccation. That's where tissue erosion occurs from prolonged exposure to moisture. Think of when you injure yourself like a cut and you put a Band-Aid on and you're constantly washing your hands, but you keep that Band-Aid on and the wound starts to not really heal that well, that's maceration, overhydration of the cells. Think of also when somebody has a pressure ulcer in their coccyx, but they're incontinent. They might have trouble with wound healing if they are incontinent of urine and keeping that area moist constantly. Trauma, so repeated trauma to a wound in the area results in delayed healing or inability to heal. Edema to the wound can interfere with blood supply, resulting in inadequate oxygen and nutrients to help heal that tissue. Infection, so that's accumulation of bacteria, increases the stress on the body, requiring increased energy to deal with the invaders. And an infection requires large amounts of energy that doesn't allow then the wounds to heal properly. Excessive bleeding. Bleeding results in large clots. Large clots increase the amount of space that must be filled during healing and interferes with oxygen diffusion to the tissue. Necrosis, that's dead tissue. Once there's dead tissue, there's wound healing delays. Dead tissue appears as slough, moist, yellow, stringy tissue, and then eschar appears dry and black, leathery tissue. Healing of wound will not take place with necrotic tissue in the wound, so mechanical removal of that must happen before it can heal. Biofilm. Wound biofilm results as wound bacteria growing in clumps embedded in thick, self-made protective slimy barrier of sugars and protein. This barrier contributes to decrease effectiveness of antibiotics against the bacteria and decreases the effectiveness of the normal immune response. Systemic factors include age. Children and healthy adults will heal more rapidly. Circulation and oxygenation. Adequate blood flow is essential to wound healing. If there isn't enough blood flow, there isn't oxygen exchange occurring. Nutrients are not exchanging, and so there is delayed wound healing. Nutritional status is one of the biggest factors in wound healing. That involves high protein, high vitamin C for healing. Wound etiology, so specific conditions of the wounds affect healing. Think of diabetic wound ulcers or pressure ulcers, venous wounds. Those typically have longer periods of healing. The health status of the patient, so if they're on corticosteroids or they're post-operative, may delay some healing. Immunocompromised patients will definitely have delayed wound healing just because their body is already fighting other things. The use of medications, certain medications might constrict blood flow. They might do things that will prevent healing from occurring. And then the biggest thing is adherence to treatment, especially with chronic wounds. They may be hard to keep doing what the patient needs to heal their wounds. So that's a huge factor, and that affects wound healing. Primary skin lesions are usually skin changes that originate on healthy skin and are directly associated with specific causes from a disease or something in the skin. Secondary skin lesions result from changes in primary lesions from external causes such as scratching, trauma, infection, or changes caused by wound healing. See Table 55-2 in page 1806. You can see the descriptions of each type. For example, macules. Macules are non-palpable skin color changes, typically brown, white, tan, purple, red. Some common ones we know are freckles, flat moles, petechia, port wine stains, and even ecchymosis. Papules are elevated. They're palpable, solid mass with a circumscribed border. Think of elevated moles or nevi, warts are some common ones. Just take a look at that chart. There are descriptions of each and really good pictures so that you get familiar with what they are. The reason you need to know the different skin lesions is because you will be assessing them. You need to know that they vary in size, shape, and then the causes. You need to know type and appearances. You need to know the difference between primary and secondary, and having a good idea of what each type of lesion is will help you in assessing and documenting these type of lesions correctly. You want to notice any color of the lesions, maybe any redness. Is there heat coming from it, pain or swelling? The size you would measure, or is it in a localized area, or does it go all over? Is it patterned? Is it oozing? And what's the distribution of the lesion? Is it bilateral? Is it on one side, linear, circular? These are all different things to describe the assessment of lesions. Further, not just about lesions, when you're assessing wounds of any kind, you're going to need to assess the size of the wound. You're going to measure that, depth of the wound, if there's presence of undermining, tunneling. You're also going to want to notate the drainage. For drainages, you're going to want to know what serous drainage is. Serous is clear fluid that leaks out of wounds. It's normal in small amounts. It's a sign of a healing wound. Sanguinous is bloody. It's red. It's typically can be bright red. Serosanguinous is the mixture of the serous and sanguinous fluid. It's going to be pink, clear, red. And then purulent drainage is infected drainage. It's pus. The appropriate term for pus is purulent, and it's not the other word. Common skin conditions include candida, which is a yeast infection of the skin. It's an overgrowth, can cause red rash, itching, swelling, scaling of the skin. Candida usually thrives in a more moist environment. The other skin infection caused by fungal is tinea, and there are many versions of tinea, but it is commonly known as ringworm, and its characteristics of it being rounded on the skin. It tunnels under the skin. Tinea infections affect the body, the head, the body, the groin, feet, and nails, and it typically, there's different kinds. There's tinea capitis, which is the head. Tinea carporosis is in the body. And, it's just depending on where it is. It is a fungal infection, and it is highly, highly contagious. Other infections include parasitic infections. The ones we're going to focus on are scabies, which are typically little mites found in all the parts of the world, but they burrow under the skin, causing a rash. Bed bugs are another one, very contagious. They are parasitic, they bite and can cause rashes, and then ticks as well. Parasitic, cause rashes from their bites. Special notice of ticks. There are certain ticks that can cause certain conditions, such as, oh my gosh, now I'm blanking what the name of that is. Ticks can cause Lyme disease. And then the other skin conditions we're going to focus on greatly are your wounds. We're going to talk about different kinds of wounds, and then we're going to talk about pressure ulcers. When patients have wounds, they can suffer some psychological effects. First and foremost, they can have pain. Pain is part of the trauma. Anything that cuts the wound can be small or big, but it'll cause pain. And although pain can be considered a physical complication, it has a large part of or has a large psychological component. Pain from wounds is often increased by activities such as ambulating, coughing, moving in bed, or dressing changes. The actual pain might be worse by the patient's, or might worsen by the patient's apprehension of such activities. Anxiety and fear is also huge psychological aspect of wounds. Anxiety and fear are common due to having a wound, having potential disfigurement, apprehensive of the possibility of the wound reopening, or how much privacy will be lost depending on where the wound is. When caring for patients with wounds, demonstrating acceptance and empathy is super huge because this is a huge deal especially if this is a disfiguring wound. We talked about how some wounds can cause pain, and pain will impact the activities of daily living. Patients with wounds won't want to do things that they usually do because of the pain caused by it. Physical, financial, and medical restrictions can result in to perform their activities of daily living. And lastly, changes in body images, which goes with that fear and anxiety. Wounds can disfigure somebody. As a society who puts beauty at the top of everything, skin and tissue trauma can cause severe scars, and this can be especially harmful for certain populations. And so, understanding this, providing therapeutic communication, helping the patient express their fears and anxieties regarding those body changes or body images changes is going to be crucial. We are going to focus on pressure injuries. While understanding how wounds heal and the phases of wound healing, we need to understand how they occur. Pressure injuries are localized areas of necrotic soft tissue. Occurs when pressure applied to the skin is greater than the normal capillary pressure over a period of time, sufficient enough to cause injury. There is no known amount of time. A pressure injury can occur even with just 30 minutes of cutting off circulation to the body part. And so it is crucial that we understand how these are occurring so that we can prevent them. If you look at the diagram here, the picture, this is showing you of the bony prominences that are highly likely to get pressure injuries. We see a lot of them in the sacrum, in the ischial tuberosities, here in the knee area, the ankles, and then the heels are huge. But this doesn't mean that they can't occur in other places. So we have to be very mindful that these are highly likely areas, but can occur in other places. Mechanical forces contributing to pressure injuries. So external pressure compressing blood vessels, friction or shearing forces tearing or injury to the blood vessels, microclimate, temperatures and moisture of the skin. If you look at this diagram, if we move a patient in one direction and then the skin goes in the other direction, we run a huge risk of causing an injury to this patient. The major predisposing factor for a pressure injury is external pressure applied over an area, which results in occluded blood capillaries and poor circulation to tissues. The insufficient circulation deprives the tissue of oxygen and nutrients, which leads to ischemia, hypoxia, edema, inflammation, and ultimately necrosis and ulceraflammation. A pressure injury may occur in as little as 1 to 2 hours. Like I said, it's not exactly known the time. It all depends on the patient, but minimum 30 to an hour 1 to 2 hours. This is why most facilities have Q2-hour repositioning of patients that can't move themselves so that we prevent formation of pressure injuries. Friction occurs when two surfaces rub against each other. The injury, which resembles an abrasion, can also damage superficial blood vessels directly under the skin. And then shear results when one layer of tissue slides over another layer. Shear separates the skin from underlying tissue. Shear includes shear stress that forces and shear strain, the distortion or deformation of the tissue, secondary to the shear stress. The small blood vessels and capillaries in the area are stretched and possibly tear, resulting in decreased circulation. The microclimate refers to the changes in temperature, humidity of the skin that comes into contact with a support surface, such as a bed or device. Skin that is moist does not have the same tolerance for pressure and shear forces as skin that is dry. When skin is damp, like from incontinence or perspiration, it requires less friction to blister and abrade, which can lead to a pressure injury. Factors that also affect pressure injury development include aging skin. We know that as we get older, we have decreased fat, decreased collagen, so decreased cushion in our skin, chronic illnesses, immobility, malnutrition. So think about immobility. That's the biggest cause factor of pressure injuries. When patients are not moving, they're putting a lot of pressure on those bony prominences, cutting off the circulation, thus causing pressure injuries. Malnutrition, because of that less protein and less nutrients, a patient can develop pressure injuries. Fecal and urinary incontinence is a huge one. Fecal and urine are typically acidic and then cause skin breakdown. Altered level of consciousness, if they are unaware that they need to move around, then that will cause pressure injuries. Spinal cord and brain injuries, again, it's that mobility aspect. And then neuromuscular disorders, also are huge factors of pressure injury. How do we evaluate or assess risk factors for pressure injuries? Well, we want to evaluate the level of mobility for our patients because we know mobility is a key factor in prevention of pressure injuries. Assessing neurovascular status, so we want to ensure there's no numbness, tingling, and if there is, that we're checking these areas constantly because patients may not be able to tell you that they have pain or that an injury has occurred. Evaluate circulatory system. Pressure injuries are lack of blood supply to the area, and so circulatory status is important. Evaluation of nutrition and hydration are important because these two play a key role in healing. And when pressure injuries occur, we need to have the patient in optimal nutrition and hydration for healing. Studying lab results and knowing what kind of labs can be out of whack from pressure injuries. For example, if it's an open wound, we want to assess labs that may indicate infection. Determine the presence of incontinence. So if our patient is incontinent, we're constantly cleaning them up. We don't want them having skin breakdown from their incontinence. There are medications that can cause pressure injuries, not by actually causing it, but for example, if they're taking a diuretic, then they're incontinent, then they're actually voiding a lot more and having incontinence problems that we're going to need to be aware. Then this is just an example. There are plenty of other medications that can cause issues. Stages of pressure injuries. So stage 1 is non-blanchable erythema. It's intact skin, so Stage 1, the skin is intact with a localized area of non-blanchable redness, which may appear different in darkly pigmented skin. The presence of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Color changes do not include purple or maroon discoloration. These may indicate deep tissue injury. Stage 2 is a partial thickness skin loss with exposed dermis. Partial thickness with skin loss with exposed dermis. The wound bed is viable pink or red, moist, and may also present as intact or ruptured serum-filled blister. Adipose tissue is not visible, and deeper tissues are not visible. Granulation tissue, slough, and eschar are not present. Stage 3 is full thickness loss of skin in which adipose or fat tissue is visible in the ulcer, and granulation tissue and epibole or rolled wound edges are present. Slough and eschar may be visible. Stage 4 pressure injury is full thickness skin tissue loss with exposed or direct palpable fascia, muscle, tendon, ligament, cartilage, or bone in ulcers. Slough and or eschar may be visible. Epibole rolled edges, undermining, or tunneling may be present. And then unstageable or unable to stage it is full thickness skin and tissue loss in which the extent of tissue damage within the ulcer cannot be confirmed because it is obscured by slough and eschar. Then there's deep tissue injury. So deep tissue injury is non-blanchable deep red, maroon, and purple discoloration. Non-intact skin with localized area of persistent non-blanchable deep red, maroon, purple. The process leading to deep tissue injury begins 48 hours prior to color changes. Pain and temperature changes often precede skin changes. Discolorations may appear differently in darkly pigmented people. Look at box 33-4 to understand more of the stages of pressure injuries. As nurses, how do we prevent pressure injuries? Biggest thing is assessing the risk for patients daily. You will learn about the Braden scale in class. This is a screening tool that is used in most facilities to screen patients for risk of pressure injury development. Cleanse the skin routinely. So skin hygiene is huge in preventing pressure injuries. Maintain higher humidity, use moisturizers, protect skin from moisture, minimize skin injury from friction and shearing, proper positioning, turning and transferring, appropriate support surfaces, nutritional supplements if needed, and then the biggest thing is improving mobility and activity. If the patient is completely immobile, then that means that they're going to be passively mobile, and as the nurse, you're going to need to delegate this task to have your CNA or tech turn your patient every 2 hours. Nursing interventions for patients with pressure injuries include relieving pressure, positioning the patient at minimum every 2 hours, using pressure relieving devices. There are so many devices out there in hospital settings to prevent injuries. Improving mobility if possible, sensory perception and tissue perfusion, improving nutritional status, reducing friction and shear, and then minimizing irritating moisture to the skin. Continue with your nursing interventions. So to promote pressure injury healing for deep tissue injuries, it's immediate pressure relief. For stage 1 is maintain nutritional and fluid and electrolyte balance, reduce friction and shear, avoid moisture to the skin. Stage 2, clean with sterile saline, dressing changes as ordered, promoting pressure injury healing. Stage 3, So characterized by intensive tissue damage, so debridement may be required of the necrotic tissue. Always explain the procedure to your patient and prescribe any pain medications or administer any pain medications. Stage 4 may require surgical intervention. Other treatment methods include debridement, wet to dry dressings, mechanical flushing of necrotic and infective exudate, application of prescribed enzymes, preparations that dissolve necrotic tissue, surgical dissection. After the pressure ulcer is clean, a topical treatment is prescribed to promote granulation, and then vacuum assisted closure or hyperbaric oxygen treatment may be used. Ultimately, you want to prevent pressure injuries, and there are a lot of interventions that can be done to prevent these things. However, if they are not prevented, there are interventions to make sure they don't get worse. Understanding how the skin, the anatomy and physiology of the skin, and pathophysiology of wounds and pressure injuries is crucial. So this concludes the lecture. Please come to class with your questions. Thank you.